to Respiratory HQ. I'm Tanya Peel, and if you're watching this video, you are more than likely a respiratory therapy student. It doesn't matter where you are in your journey in your program. You can maybe just starting it, you may be just about to graduate. Either way, I think you're going to find this information really beneficial, because what I'm going to do for you is to start categorizing, classifying disease states and disorders. And when you do that, it makes a lot of things become much easier. For example, patient assessment will become easier. Some aspects of mechanical ventilation will be easier. Pulmonary function testing will become more simplistic if you just have the separation in these disease states and disorders. Because everything we do in respiratory care revolves around assessing your patient, diagnosing the disorder, and then treating it. And that all boils down to anatomical alterations. So I call this my 3 steps to success, because really we want you to be successful. We want you to successfully complete your program. We want you to successfully pass your MBRC exams on the first try, and ultimately we want you to be able to successfully care for your patients in clinical practice. So let's get started. All right. In respiratory therapy, in the hospital, we typically take care of patients that fall into 2 primary categories. Those that have obstructive disorders and those that have restrictive disorders. All right. We know what the obstructive disorders are by remembering the acronym CBABE. So C stands for cystic fibrosis, B for bronchiectasis, A for asthma, B for bronchitis, but we're really talking about chronic bronchitis, and E stands for emphysema. All right. So some of you that are towards the end of your program, you're probably saying, well, COPD is not on that list. And it isn't actually listed on this list, but it is on this list. COPD is actually a combination of chronic bronchitis and emphysema. So a person can have just chronic bronchitis and we can say they have COPD. They can just have emphysema and we say they have COPD. Or more than likely, in the same chest wall, they have a little bit of both diseases going on. Okay, so COPD is on this list. It's just categorized as chronic bronchitis and emphysema. All right, so these are our obstructive disorders. Pretty easy, just 5 of them. So that means almost everything else is going to be a restrictive disorder. So these are not all of the restrictive disorders, okay? I don't want to lead you astray, but these are the big ones, okay? These are the ones that you're going to see over and over in clinical practice. These are the ones that we're going to test you over and over in respiratory school, and these are the ones that you're going to see quite often on the MBRC exams. So I tell my students to remember the A's and the P's. So we start out with an A, we end with an A, and the P's are in the middle, okay? So atelectasis, pneumonia, pulmonary edema, pneumothorax, pleural effusion, ARDS. So all of these we can classify as restrictive disorders. So we've done a big separation, obstructive and restrictive. All right, here's why this is important. Obstructive disorders are disorders of the airway. Okay, when we say the airway, we mean the bronchi, the bronchioles, the airway of the lung. And so every one of these disorders, even emphysema, have to do with the airways, because in emphysema, we're also talking about the smallest of small airways, the terminal and respiratory bronchioles. Right? Whereas your restrictive disease states are disorders that cause problem in the alveoli. So this separation and distinction is really beneficial, because airway disorders will not respond the same as alveolar disorders, and vice versa. All right, so we have disorders of the airway, those are CBABE, and disorders of the alveoli, which is pretty much everything else. All right, so this is our step 1, categorizing these disorders and disease states. Step number 2 is understanding your anatomical alterations. That's a pretty big word there. Let's just pick it apart. So alteration means a change, right? Anatomical is anatomy, a change in anatomy. So if we're talking about the airways, we're talking about how the airway changes. Does it get bigger? Does it get smaller? Okay. If we're talking the alveoli, how does the alveoli change? Are they collapsed? Are they full? Is there a lot of fibrosis in them? How a structure changes from normal is an anatomical alteration. And so here's the key to things. If you know your anatomical alterations, this is what alters physical assessment findings. This is how we diagnose a lot of disorders, and this is how we treat these disease processes. So knowing your anatomical alterations is so very, very critical. All right, so common anatomical alterations. We can put these in obstructive and restrictive disorders. So our obstructive disorders, remember, these are airway disorders. And these are the 4 anatomical alterations that you're going to see over and over and over again. A bronchospasm, okay? So this picture, I'm going to use it to illustrate the first 3. So a bronchospasm, if you look and you see these smooth muscles that are wrapped around the airway, a bronchospasm is when those smooth muscles contract, okay? And so if those smooth muscles squeeze the airway from the outside in, the lumen of the airway gets smaller. So a bronchospasm is an anatomical alteration of the airway. Another anatomical alteration of the airway that we see are excessive bronchial secretions. So we have mucosal glands in the airway. When they secrete more secretions, we're going to have an excessive amount. And so those secretions will also take up space in the airway. It alters the anatomy. So excessive bronchial secretions are an anatomical alteration. Inflammation of the airway. So if we look here, when we're talking about inflammation, do you see this tissue? So you've got the outer diameter of the airway, but then this area here, that's tissue, and it's inflamed. And anytime the tissue is inflamed on the inside, it makes the airway smaller. Okay, so another anatomical alteration for an obstructive disease is inflammation of the airways. All right, the 4th anatomic alteration is specifically for emphysema, okay? Not for any other obstructive disorder, just for emphysema. And so this is called distal airway and alveolar weakening. Basically what this means is a little bitty airway leading to the alveoli and the alveoli, both of those, the airway and the alveoli, start losing elastic fibers. Okay, that's just part of the disorder. So now we have, instead of these nice grape-like clusters of the acinus, we actually lose elastic fibers and the lungs get really, really baggy or floppy. Anyway, when that happens, a patient doesn't oxygenate as well and they have a hard time getting air out of their chest. And it's because of the distal airway and alveolar weakening. All right, so, and this kind of gives you an idea of here's what the healthy acinus looks like. You have nice grape-like clusters of the alveoli, but when you have emphysema and you have distal airway and alveolar weakening, what you actually have is loss of the elastic fibers. So we have destruction of the actual alveoli. All right, those were our obstructive anatomical alterations. And remember, obstructive is the airway. All right, so then our restrictive anatomical alterations, remember restrictive are in the alveoli. So now we're talking about the alveoli and the corresponding capillary bed. So we call that the AC, alveolar capillary membrane. All right, so things that can go wrong in the alveoli. The first one is atelectasis. That's a common anatomical alteration. So your alveoli should be nice and full of air, but if it collapses, that's atelectasis. So this is kind of showing a normal alveoli, which is nice and filled with air, but now this one here is kind of collapsed, which means we'll have lung collapse, alveolar collapse in our lungs. The second anatomical alteration is consolidation. So consolidation is when the alveoli are filled with something, whether that is pus and cellular debris like in pneumonia or fluid like in pulmonary edema. Basically, consolidation means the filling of the alveoli with something other than air. All right, and then the third anatomic alteration is an increased alveolar capillary or an increased AC membrane thickness. So basically you have your alveoli and you have your capillary bed that wraps around it, but when that space between the alveoli and the capillary bed gets thicker, and you can kind of think of that as scar tissue, when that membrane gets thicker, oxygen has a really hard time crossing through that thickness so that oxygen gets into the bloodstream, and it causes some problems. All right, so restrictive anatomic alterations, atelectasis, consolidation, and increased AC membrane thickness. All right, so far we've separated into obstructive and restrictive disorders. We put the disease states under each one, and now we know the anatomical alterations associated with each one. And just for completion's sake, I'm going to go ahead and define these disorders. Those of you that have been through your disease class in respiratory school, this is just a great review. I guess those of you that don't know what this is yet, it's really not going to help you that much. You have a whole entire class that's going to talk about these disorders. But remember, our obstructive diseases, we use the acronym CBABE. Our restrictive diseases, remember the A's and P's. And then just by definition, I'll start out with the C in CBABE. Cystic fibrosis, it's a hereditary disorder affecting exocrine glands. And so when we talk about pulmonary involvement, our mucosal glands are exocrine glands. So we have a lot of secretions that are produced in the lungs of patients with CF. So it causes production of abnormally thick mucus, leading to blockage of the pancreatic ducts, the intestines, the bronchi. And oftentimes these people, because of all the excessive bronchial secretions, that leads to infections. Bronchiectasis is an acquired disorder that causes dilation and distortion of the bronchi and bronchioles. Basically, the airways change shapes. There's a lot of mucus production that's involved in this. It's really hard for the patient to cough that mucus up because of the way the anatomy actually changes in the airway. Asthma is defined as a chronic inflammatory disorder, airway inflammation, that causes airway hyperresponsiveness, bronchospasm, and increased secretion production. All right, so even that definition right there hits all three of those anatomic alterations of our obstructive disease processes. Chronic bronchitis is technically defined as a chronic productive cough for 3 months for at least 2 consecutive years. This definition is very important in the diagnosis of chronic bronchitis. Whereas emphysema is the presence of permanent enlargement of the air spaces distal to the terminal bronchioles, the alveoli. And it's accompanied by destruction of their walls. So again, remember the one anatomic alteration on that obstructive side was distal airway and alveolar weakening, because those little airways and the alveoli lose elastic fibers. All right. And now we're talking about the restrictive disorders. Remember the A's and P's, starting with atelectasis. So atelectasis is a disorder. It's also an anatomical alteration, okay? And the true definition is incomplete expansion of the alveoli. So that means they're either collapsed or they're not fully inflated. It's called atelectasis. Atelectasis is very, very common. You're going to see it all the time in clinical practice. Pneumonia is an inflammatory process that primarily affects the gas exchanging areas of the lung, the alveoli. So basically the alveoli fill with serum, red blood cells, white blood cells, pus. It's an infection of the alveoli, and so the alveoli are filled with all of this stuff, so therefore that's consolidation. Pulmonary edema is fluid in the alveoli. This is typically, not always, but oftentimes a result of heart failure, left heart failure. And so there ends up to being quite a bit of fluid that accumulates in the alveoli. But again, it's something filling the alveoli, right? So this is consolidation that we're talking about. All right, a pneumothorax. The definition of the pneumothorax is air in the pleural space. So if you remember from anatomy, you have the parietal and visceral pleura, and basically there's hardly anything in between, just a little bit of fluid so that they move really smoothly across each other. But if air accumulates in that pleural space, what it ends up doing is compressing on the underlying lung tissue. That lung tissue, the alveoli, collapses. So a pneumothorax creates atelectasis, which is an alveolar problem. A pleural effusion, if we look over here, we've got fluid in the pleural space. Okay, so instead of air that's between that visceral and parietal layer, there's fluid of some type. And so that fluid is heavy. It bears down on those alveoli, and the alveoli collapse, creating atelectasis, so therefore it is an alveolar disorder. All right, and then ARDS. This is a very big syndrome, okay? Lots of different things can cause it, but bottom line, it can be a life-threatening condition that's characterized by really stiff lungs, okay? There's a lot of atelectasis in this. There's some pulmonary edema that happens with this. There's increased AC membrane thickness because of hyaline membrane disorder. So there's a lot of things going on, a lot of pathology going on in this, but bottom line, it causes the lungs to get really stiff, the alveoli to get really stiff. And it's an alveolar problem, right? There's going to be a lot of hypoxemia with it also. All right, so that's just defining. We've done 2 steps. We've categorized our disease process. We've talked about the anatomic alterations. And now the 3rd step is to assess the patient and treat. So when we are doing patient assessment, we're going to have certain findings. We're going to gather signs and symptoms. So let's differentiate between the 2. Signs are things that we as respiratory therapists can see or measure. They're very objective. You know, if a patient's heart rate is elevated, that's an objective number. All right, whereas a symptom is what the patient has to tell us that they feel. If they feel dyspneic, okay, if they feel nauseated, it's not something that we can identify and put a number to. It's something that that patient has to describe to us. So a symptom, the patient describes. But oftentimes, these patient assessment findings are a result of the anatomical alterations. All right, so let's just take your obstructive diseases. They're airway diseases, which by and large, bronchospasm, inflammation, and excessive secretion makes the airway smaller, right? And so there are going to be certain physical assessment findings that are common to every patient that has an obstructive disorder, okay? Same thing with restrictive diseases. There are certain patient assessment findings that'll be very common for restrictive diseases, and you'll see the same patient assessment findings regardless of their disease process. Diagnosis. Diagnosis is often related to the anatomical alterations. For example, COPD. If we're wanting to diagnose chronic bronchitis or emphysema, oftentimes there is a pulmonary function test that is done. And pulmonary function testing is one of the dreaded topics in respiratory care. But I'm telling you, if you can understand that chart, you can understand PFTs really easily, because the results of the PFT findings are a result of those anatomical alterations. So stick with me and I'll show you how to use that chart with PFTs. And then once we know the diagnosis, we're going to treat the patient. And so treatment's going to be directly related to whatever anatomical alteration they have. If they have a bronchospasm, we need to relax the bronchial smooth muscle. There are medications for that. If the airway is inflamed, we need to give medication that minimizes that inflammation. If there's a lot of secretions in the airway, we need to find a way to get those secretions out. So treatment of all of these disorders and diseases revolve around treating the anatomical alterations. So it is imperative, it is so very important that you can separate the different disease processes and know which anatomical alterations go under each one. Okay, so I am a firm believer in writing. Okay, in physically writing things down, they go into your mind together. So what I want us to do together is grab a sheet of paper. Okay, I want you to separate that paper. Oops, let me give myself. I want you to divide that paper in half, and on this side, put obstructive. And this side, restrictive. So let's just work on one side first. Let's see if I can change my point. Okay, so obstructive disorders. How do we know what they are? CBAVE. I'm kind of writing small so I have enough room to do some more stuff down here. So the C in CBAVE, cystic fibrosis. Bronchiectasis, asthma, bronchitis, and remember it's chronic bronchitis that we're talking about, and emphysema. And yes, we do have COPD here because it's the combination of chronic bronchitis or emphysema, or the two of them together. All right, so let me just erase this so I have room. So COPD is chronic bronchitis and emphysema. All right, so with these, we have common anatomic alterations. So for these top three disorders, bronchospasms, let's change colors also to separate them. So these three, bronchospasm, remember, that's the smooth muscle that wraps around the airway, making the airway smaller. Inflammation, that's the tissue in the air inside of the airway kind of swelling up, makes the airway smaller. And then excessive bronchial secretions. I'm just going to minimize this, I don't have a lot of space. Okay, so bronchospasm, airway inflammation, excessive bronchial secretions. These are the anatomic alterations for obstructive disorders. Emphysema, there's only one for emphysema, that's distal airway. And alveolar weakening. Let me abbreviate that too, okay? Distal airway and alveolar weakening. And then just remember, everything on this obstructive side has to do with the airway, okay? On the restrictive side, change my color. Okay, restrictive side, we're gonna say the A's and P's, right? We started out with atelectasis. We ended up with ARDS. There's our A's. The P's are in the middle, right? Pneumonia. Pulmonary edema. Let's see, pneumothorax. Pleural effusion. And many other ones. Okay, these are not all of them, but they're the big ones. All right, so we have anatomical alterations for restrictive disease problems, okay? Those anatomical alterations are going to be atelectasis, okay? So remember, atelectasis is not only a disorder, it is also an anatomic alteration. Consolidation. This is the alveoli filling with something, okay, like in pneumonia and pulmonary edema. Or we also have the third one is going to be an increased AC membrane thickness. So this is that space between the alveoli and the pulmonary capillary bed, if that area gets thicker, like fibrotic or scar tissue. All right, so gases will have a hard time diffusing across the AC membrane. All right, remember, restrictive are disorders of the alveoli. Okay, so really important. If you stay with me through this, I'm going to show you how to use this chart for mechanical ventilation. I'll separate compliance and resistance with it. I can use this chart to kind of make patient assessment findings much easier. This chart is super useful with PFTs, okay? So really, really a beneficial chart to be able to use in all aspects of respiratory care. So I hope you found this beneficial. I hope you find my other content on this website beneficial. And I hope to see you soon.